And then the last session of the term, towards the end, when we started some of the other year 4 stuff, year 5, sorry, module C stuff, is the other bits and bobs. We'll cover the legal stuff throughout. So things like the Mental Capacity and Mental Health Act, things which we'll cover at later points, but not this term because they don't come up as often. Things like CAMS, so like Anush mentioned, things like conduct disorder, overlap with COOP, so your dementia and delirium and how they work under the Mental Health and Capacity Act, and then sort of assorted things like dissociative disorders and conversion disorders. If there's anything you're unsure of or you could do with more teaching on, then let me know. So we're not actually going to do this case, but this is sort of a framework to come back to whilst we're talking about how to take a history of mental health assessment. I mentioned that, so Claudia's been on liaison psych, so this is literally the kind of thing that you'll see when you're an A&E on liaison psych, somebody coming in like this man, Amir, who's 27, he's taken an overdose. You don't know what he's taken, but A&E stabilized him and they want you to review him before he's discharged. So the things you need to do are threefold. You want a history, and you want to do a mental state examination, and from all of that, you can put together a risk assessment. So let's start with history. So what's the first thing you want to ask from somebody, who's presented, well, generally in any consultation? What's the first thing you want to know? Start of any history. Yeah, exactly. Patient's words, what's going on? You will have been told, you'll have been hand-overed, this patient's come in, he's taken an overdose. That's what you're getting from your fellow professionals, but what's the patient said? It's actually really, really useful in terms of, if you've got a patient who's really unwell, perhaps psychotic, what they say could be completely different to what you've been told, and it's also really, really useful in getting an idea of what's been going on. And you're presenting complaints, could be anything. The patient could be low in mood all the way to acutely suicidal or psychotic. Once you've got an idea of what's going on, what do you want to know about it? So this structure is basically pretty similar to your regular medical history. So you want what's going on, which is a presenting complaint. Perfect. Has this happened before? Is this first onset? Has a problem like this happened before? Is this a recurrent issue? Very good. Which is something you want to know, things like chest pain, for example, any other sort of physical presentation. With symptoms in general, what sort of things do you ask? Okay, was this planned? Perfect, yeah. So in something like an overdose or a suicide attempt, did they plan it or was it impulsive? Which is really, really important, because which one's more dangerous in terms of suicide attempts? Which one's more likely to be carried out again, planned ones or impulsive ones? We'll get to what Prachi said in a second. Yeah, so if somebody has planned an attempt to take their own life, it is statistically more likely to be repeated than an impulsive attempt. An impulsive attempt sort of is a bit like you could look at it sort of like a tsunami. It's out of nowhere, it comes very quickly and then ebbs back. And there might be sort of follow-up waves to it, but generally the planned ones are more consistent, which is what makes them more worrying. Prachi said, how does he feel to be stabilized now? Which is a really, really good question. Something you might see on your liaison attachments is the patient being asked, if you were to go home now, what are the chances of you trying to kill yourself again? Which is a really, really important part of the risk assessment. So that's really, really important as well. What else would you like to know? So we've said, has this happened before? Is it planned? Is it planned? How do you feel now after it's happened? By the way, this isn't specifically just for the scenario we have here with Mr. Musa. It's with any psychiatric presenting complaint. Do you want to know? So all we've got so far is why is really, really important. And don't be afraid from asking that question. It might, one of the things in psychiatry is it's the specialty that you get to pry the deepest And why is a really, really important question. Don't shy away from it. Obviously, ask it in a sensitive manner, but it's really important to know why. It could be something sudden, triggered, like a breakup, or it could be something which has been planned over time, and you find out things like job loss, or perhaps even something more sinister like psychotic depression, where somebody's hearing voices telling them to do it. So that's a really, really important question. But generally, as with your physical side of things, you want to know, did anything trigger it or make it worse? Has it been associated with anything else? In psychiatry, that's things like substance use, hearing things, believing odd things other people might not believe. When did it start, and what's its pattern been like? Is it constant? Does it come and go? Okay, so past psychiatric history is quite important, and that's something that was mentioned earlier by, which was, has this happened before? So what do you want to ask somebody who has presented with, let's say with this patient, what do we want to ask about other than has this happened before, to get an idea of if there's any past psychiatric history? Yeah, perfect. Do you have any previous contact with mental health services? Yep. Any self-harm? Very good. And if they say, yeah, I do have contact with mental health services, what do we want to know about that? Perfect. Have you visited your GP? Yeah. So, just seeing what you said, what do they think was going to happen when if somebody has attempted suicide? That's a really, really important question. There's a big difference between somebody going, well, I didn't think it would kill me, or, well, I thought I'd be dead. And this is a point that's often brought up, but it's quite an important one. For example, we know generally as medics that the recommended dose of paracetamol shouldn't exceed 1 gram 4 times a day. So that's 2 500 milligram pills 4 times a day. But taking 6 grams probably won't kill you. However, if somebody takes 6 grams, so that's 10 pills, and thinks that it genuinely will kill them, that's far more dangerous in terms of risk than the 80-year-old with a bad headache who took 15 or 20 grams because she wanted the headache to go away, didn't realize actually that's way too high a dose. The two things are one is physically worse, sure. The 20 grams is obviously worse than the 6 grams, but it's the intent which matters. So that's why that's a really good question to ask for, actually. So what do they think was going to happen? Okay, so have you visited your GP regarding your mood? If they say I have had contact with mental health services, what more details can we get from that? Perfect. Team, really good. Teams and admissions. You know that this is something quite long-standing, quite severe if they are under a mental health team, particularly if they're under a care coordinator. You might hear the phrase, this patient has a care coordinator. All that means this patient has pervasive needs, which mean that they need to have a member of the mental health team, usually it's a social worker or a mental health nurse, who coordinates their appointments, their medication, sort of the social side of things, like application for supported housing for them. Generally, these are more unwell patients who need this, patients who are unwell enough that they don't have the ability to independently organize these things, like their finances, like their bills and things like that. A lot of people might be under a community mental health team. Admission is really, really important. Have they had any admissions to hospital? How long for? So like William said, how long was the admission for? And what happened during the admission? Were they treated? What else do you want to know about if they have been admitted? What do you want to know about the admission? Perfect. Sectional or informal? Did they agree to the admission, or did they have to be taken under the Mental Health Act? Additionally, it can be quite useful to know if somebody went to psychiatric intensive care units. So psychiatric intensive care units are wards designed for very unwell patients. So I don't know if any of you will be placed on them given the COVID circumstances and everything, but these are patients who are really unwell, are a higher risk of aggression or hurting themselves or other people. So we've got, in terms of existing stuff, do they have a diagnosis? Are they known to mental health teams? Do they have a care coordinator? Have they been admitted? When was the last time? And has something like this happened before? So in terms of suicide attempts, have they had previous suicide attempts? Because remember, one of the biggest risks for completed, as much as I hate that phrase, but completed suicide is having a previous suicide attempt. Okay, so now we get onto drug history. So beyond the usual, the medical side of things, are you taking anything medically? Are you allergic to anything? What else do we want to know? So let's start with the psych side of things. So what do we want to know about? So let's say they are on medication. Perfect. What is the medication? What dose is it? What's the frequency? Which a patient might not know, but it might be on their notes, for example. This is really important with any medication, really, but there we go, Claudia said it. With any medication, it's important to know if the patient's taking it, if they're concordant or compliant. This is especially important in psychiatry because, for example, if you have a patient who is on antipsychotics because they have schizophrenia, if they stop taking them, there is a really strong chance, above 85%, I think, that they will relapse. If there is a patient who there are strong doubts about their chances of complying with their medication, what is an option that's sometimes available to mental health services? So you've got the home treatment team, you've got the community order. So quickly, just let me ask William, what's a community treatment order? So what's a CTO? Whilst I'm doing that, yeah, so Christy said an intramuscular depot, perfect. Depots, which are intramuscular injections, are given to patients who there is a doubt whether they, in the first place, will take the medication. So you might, well, hopefully you don't have to see it, but in cases you might see a patient who is very resistant and is unwell enough that they don't want the medication, might have to be restrained to be given the medication, usually intramuscularly, because you can't make them take it orally. Or if it's a long-term thing where you want to discharge the patient, but you think either some patients, for example, get better, then think, I don't need the medication and stop taking it. Others just don't remember, others don't want to take it, in which case you get them to come in for their injection, which could be monthly, 2 weekly, depends on the medication. Williams mentioned something called a community treatment order. This is when a patient is obliged to come to hospital or their GP or a certain centre to take their treatment. This can only be done to certain patients. What's the requirement for a community treatment order? What does the patient have to have been under in order to receive a CTO? Perfect, the section 3. So if you have a patient on section 3, we'll talk about sections more in another session, but remember your section 3 is your 6-month treatment order. And do you think the patient, there's a good chance the patient will not take their medication once they're discharged? You can put them under a community treatment order. This means they are legally obliged to attend to receive their medication, usually as a depot. What happens if they don't turn up? If the patient under a CTO doesn't turn up to their treatment appointment? Yeah, they're readmitted under a section 3 again. If they don't turn up, they're readmitted under a section 3. So just to go up, Alexis has said whether the patient's having trouble taking them. What did you mean by that? So what specifically are you asking for? If you're asking the patient, do you have any trouble? So yeah, and in that case, what's one of the things that can cause decreased compliance? That kind of question would sort of be going towards. Perfect, side effects. Remember, psychiatric drugs can have really horrible side effects. A lot of them do, which is a major issue with compliance in that they will often deal with your psychosis, but they'll cause several other problems which make patients not want to take them, which we'll talk about once we're covering the things. Covering the medication specifically. You won't be tested on depot formulation names. I'll say that from now. So things like, you don't need to know things like Zopixol or which is Zuclopenfixol intramuscularly, or the different sort of preparations. But just like how when you actually start working, it's useful to know what certain brand names are. Some of these can be quite useful because you might see the staff just throwing it around. And it's like, I don't know what this is, but it's worth knowing them for your own knowledge. But you won't be tested, for example, on Zopixol IM or Clopixol, things like that. Okay, so we're taking the drug history. What other sort of thing comes hand in hand with, well, prescribed drugs? That's really important in psychiatry, since we're on the topic of drugs. Substance misuse. It can be really awkward to ask about substance misuse. Whilst you're clerking in a patient, let's say in A&E, in psychiatry, it's a must. Substance misuse is very, very common in patients with severe mental illnesses. It's really complicated. Why? For some people, it's a coping mechanism. Other people, it might have happened. It might have been a risk factor for developing it. So things like substance misuse, substance-induced psychosis, or you have people who have really bad depression and their way of coping with it is drinking heavily or using cannabis or things like that. So it's really, really important to ask about these things. How often they use it, what they're using. Sometimes, and with time, you may end up becoming a bit more specific. So for example, somebody might say they smoke weed. You might want to be asking, well, do you know what type you're smoking? Because there are different outcomes associated with different strains of marijuana. So obviously higher THC containing ones like skunk have much worse outcomes than things like hashish or resin. Similarly, you might want to know if they're taking anything synthetic. So a big problem in London, the Camden area, is a synthetic cannabinoid called spice, which can be fatal and is associated with a really high rate of drug-induced psychosis. So taking a good history in terms of substance misuse is really, really important. Talked a bit about forensic history before I managed to sort out the technical difficulties. So it's been mentioned that it's important in terms of things like any incidents with the police, things like that. That's really important. What kind of incidents is really important to ask about? So somebody could have had public disordered drinking or something like that, or they got into a fight with a police officer and they were charged for it. What's really important to know about in terms of the type of offence? What type of offence are we particularly worried about? But yeah, violence, basically. Violent offense. If somebody's got a history of violent offences, that increases risk to others. So I'll talk about the paradigms of risk later. If somebody's got a history of violent offences, then you might be thinking putting them on the intensive care unit, for example, because they're going to need more management. The main thing with psychiatric intensive care is not only is the security measures higher, but they've got more staff. They've got significantly more staff, which means they're better able to handle patients with more significant needs. So violent offences are important. Have they been to prison? Are they on parole? When we talk about sections a bit later, I'll briefly mention forensic sections. This, again, isn't necessary for your exams. It's just useful because sometimes you might be on a ward and you see something like a patient's in section 37 and you go, I've never heard of that before. All it is it's a section 2, but for people who are under the prison system. So if somebody's been moved to a ward and they have a forensic history, they don't go under a section 2, they go under a section 37, for example. But we'll talk about that a bit more. We've talked about personal history a bit, so stuff like the pre-morbid personality, which just means what was a person like before, and things like development. So usually it's a bit difficult to get that from the patient, which actually brings us to another thing, which is often patients who are unwell either may not be able to give the best history or may not want to give you a history. So what is it quite important to do in psychiatry, and what might you often see doctors or nurses or other associated mental health practitioners doing? Taking a collateral history, yeah. So you'll often see them on the phone ringing a family member or even the GP, because if a patient's really unwell, They often might not be able to give you a history. Say if somebody's really manic and is telling you that they are the second coming of Christ, for example, there's not going to be much obtained from asking them, so, what was your childhood like? Or, so how was school for you? It's not really going to get much out. So collateral histories are really, really important. And that's often where you can get things like your developmental history or pre-morbid personality. Social history is really, really important. We've talked a bit about that. This is often important for things like discharge. So can you, how comfortable are you discharging a person back to the streets, as opposed to if they actually live in supported living? Do they work? What's happened recently in life? Any particular triggers? Why is it important to know about who they live with, or if they live with anybody? What their relationships or dependents are. So there could be a trigger, yeah. And you want to take care of them, perfect. An abuse, okay. Safeguarding is a really, really important thing. And in terms of the mental health side of things, often that safeguarding is not safeguarding the patient, other people from the patient, it's safeguarding the patient from other people. Say you have a 20-something-year-old man who's got pretty bad Down syndrome, which is associated with schizophrenia, and you know that they live with three other people, and they never seem to be they get their benefits, but they always seem to be unable to pay rent, things like that. You might start to become suspicious that somebody's financially taking advantage of them. On the other side of things, of course, if you've got a lady who's become really unwell, really depressed, and needs to be admitted, it's important to know if there's anybody at home. Let's say if there are children, or let's say she's a carer for a parent. It's important to know, A, are these people safe? B, is there going to be anybody to look after them if they're admitted? So that's really, really important. So the who are they living with side of things is quite important. And then family history, often missed, can be really quite important. Why is family history important? Yeah, family history of, there you go. Some conditions can have genetic risk factors, but sometimes obviously if you find out that there are 3 people in this person's extended family within 2 generations who have a psychotic condition, yep, there is clearly a genetic element here, and we know that things like schizophrenia and bipolar have a very high heritability. But also sometimes you could pick up a bit of a pattern. So, you've got, let's say you're seeing a 20-something-year-old man who has started to become very aggressive, very sort of agitated. And you speak to his mum, and she says, well, actually, his dad got sent to prison in his 20s for a similar thing and then died in his 40s. And same thing happened to his mum, so the patient's grandmother. And you say, well, what did the father pass away from? And they go, oh, he eventually sort of got dementia in his 40s, and he had some problems with movement, but I can't really remember what was going on. You might start thinking, hold on, is this a functional psychiatric condition? Wait, this patient might have Huntington's disease. And that does happen. It's rare, but you will speak to psychiatrists who go, yes, so it turned out my patient actually had Wilson's disease, or it turned out my patient had XYZ. Past medical history obviously is really important. There is a particular medication that you want, there's a physical health medication that you want to know if your patients are on. Any guesses what that could be? Because they can cause everything, including triggering psychiatric presentations. So when you're asking about medication in general, your patient's also got rheumatoid, or they're on chemo, or shut up, Anoush. Stop spoiling things. Perfect. Steroids. Yeah. You want to know what medications people are on, because a lot of medications can trigger psychiatric presentations, but steroids especially. There was a lady on the ward that I was on who got some steroids before her rounds of chemo and developed steroid-induced mania, and that's what she'd been admitted for. So it is really important. It's not, yeah, like Anush said, it's not uncommon at all. It's really important to be aware that iatrogenic psychiatric presentations, aren't uncommon, and steroids definitely aren't uncommon. Okay, so that's sort of the history stuff. That's the history stuff summarized. If there are any questions about that, drop them down, but let's talk about the mental state examination. So your mental state examination is, again, your bread and butter examination. It's the one examination that you can do without really triggering anything. A large part of it is just by watching and listening. So also just really quickly, when we talk about associated symptoms in psychiatry, these are the sort of main ones. So you've got your biological, you often hear them with regard to depression, but they apply to any psychiatric condition really. Anxiety, you can get things like chest pain, even with schizophrenia, you can get increased fatigue, for example. But remember, your energy levels can go both ways. People become hypersomnic or insomnic. The other really important thing is there are certain disturbances which are quite sensitive or specific for particular mental illnesses. So early morning waking, which is when a person falls asleep fine, but then wakes up at 3 a.m. and struggles to go back to sleep, is very common in dementia. You've got your sympathetic symptoms and anxiety. And it's really important to ask about libido changes, not just in people who are first presenting, but also in people who've been started on a medication. So what class of medications actually quite commonly causes sexual dysfunction, whether that's things like erectile dysfunction or anorgasmia, which a lot of people are on. SSRIs, perfect. SSRIs can cause a lot of sexual dysfunction, so it's always important to ask about things like that. And then your psychological ones are a bit more obvious, so things like a state of worry and anxiety, or if they've lost enjoyment in things which they previously enjoyed, which is anhedonia. But social is also quite important, and these are the ones which often other people, like family, will be able to let you in on. So is the patient more withdrawn? Is the patient irritable, aggressive, that sort of thing? So we'll talk about the mental state examination. Aseptic is the mnemonic to remember it, and we'll go through each one by one. So we'll start with appearance. What sort of things are we looking out for in appearance? Perfect. How kempt are they? And if a person's not well kempt, what are you starting to think about that? Yeah, are they unwell enough that they're starting to neglect themselves, not be able to look after themselves, maintain their basic hygiene? That's really, really important. So how kempt are they? The most, yep, good. So that's in terms of behavior. Does it look like they're focusing elsewhere? Are they able to focus? Are they able to focus on you, hygiene and self-harm? The most important point, I would say, from appearance and behavior is actually something which is pervasive through medicine. If I told you a patient had a CRP of 150, what would you want to know? Let's say we're in AMU, we're in an acute medical unit, and I say, hey, this person's got pneumonia, they've got a CRP of 150. Are you happy with just that bit of information? Do they look unwell? Yeah, that's important. Baseline, perfect. Yeah. What is the trend? What's the trend? Yeah, sorry, that question was phrased a bit weirdly. I apologize. But what is the trend in this? But if a patient consistently turns up slightly disheveled, and you know their baseline is that they're able to get by, they've been on medication for 20 years, they're able to get by, they don't do great, but you know, they haven't changed much over the years that you've seen them, that's okay-ish. But if you're seeing a person who every time you see them, really well kempt, dressed really smartly, everything sort of done up, and then one appointment they turn up looking quite, different. You can see that they haven't shaved, for example. They've sort of developed facial hair, or they just look tired, things like that. That's a significant difference. That's a deviation for the baseline, and that's an important thing to pick up on. So we've got sort of how kempt are they, things like that. And then on the behavior side of things, where are they focused on, but also, is it appropriate? Is it appropriate for, what you're talking about? Are they calm? Are they angry? Are they sat down whilst you talk to them? Are they stood up? Do they look confrontational, aggressive? This is often for your own safety as well, not just for assessing the patient. So just generally what their body language is like. This is also the kind of place where, again, when we're talking about ruling out organic causes, so physical reasons for a psychiatric presentation, this can be quite useful. So, let's say you are seeing somebody who's coming being quite paranoid and agitated, and you notice that they've got very tremory hands. Their hands are very tremory, and their eyes are a bit all over the place. What might you be worried about? Is this person starting to become functionally psychotic, or maybe there's something else going on? It's very non-specific, but it's something that you would want to look out for. Yeah, so side effect of a medication is really important. Physical cause, withdrawal from a substance. So this being described, sort of the tremor and beginnings of nystagmus, is often along with agitation and paranoia, are the first few symptoms of delirium tremens, which is a really common presentation to psychiatry wards. Patients who are withdrawing from alcohol, who've become quite mentally unwell because of it, and then need their detox regimen with the chloride epoxide. So looking out not just for, well, okay, how's the patient coming across mentally, but is there anything else sort of weird? You look at, so earlier it was mentioned, do you see any scars? Are they new? Has this patient started self-harming? How much are they wearing? Is it the middle of summer and the person is wearing really thick woolly jumpers? Maybe they're self-harming. Maybe they just feel really, really cold, and it's a thyroid problem. So that's the sort of thing that we're looking at there. And this is the sort of thing which you can get without really saying anything to a patient, which is why it's worth having a good look at a patient. And also, if you're seeing someone in the community with a doctor, asking them, do they look, how is that usual for them? Because you might notice something and it seems a bit weird to you, but they go, actually, that's always what they're like. That's Mr. David's baseline. So then that's quite useful to know. Speech, we won't dwell on too much, because again, it's one of the ones which you don't need to take too much from. Are they speaking, for a start? Somebody might be sat in the corner, you've gone to a police station to assess somebody who's been arrested, and they want a mental health assessment. Are they sat in the corner of the cell not speaking at all? That's something significant. Or are they speaking really, really fast? Does it seem like they're manic? Are they shouting at you? Are they angry? Are they a bit suspicious when they talk to you? What's their volume like? So those are 3 domains of speech. So rate, tone, and volume. You might often just see normal RTV written down. But a speech, again, is one of the ones which is important, but also fairly self-explanatory. You write down what you hear. Are they shouting? Are they talking? How slowly? How fast? So we move on to the E, which is emotion. Emotion's broken down into 2 components in the mental state examination. What are they? And this is something which people get tripped up on a bit. Perfect. Mood and affect. What's the difference? Yeah, perfect. So mood is subjective, affect is objective. When I ask you, how do you feel? What you tell me is your mood. Mood is the thing that you only get mood from a patient who's actually telling you. The patient tells you what their mood is. In order to gauge what somebody's mood is, you need a communicating patient. Affect, you don't need that. Affect is something you can get without the patient saying anything at all. It's what you're picking up. Often it's compared to things like the weather and the difference between weather, which is quite subjective, and it's like, oh, it feels a bit cold, and climate, which is objective. The temperature is 13 degrees. But just remember that affect is entirely what you're picking up. Mood is something which the patient reports to you. And they can be out of line with each other. You could ask me, so how are you feeling today, Mr. El-Shahabi, if you're seeing me in an appointment? And I could be on, yeah, I feel really good. Everything's great. It's fine. And my mood, which I'm reporting, is good, but clearly my affect is not. They're not in line with each other. So it's quite important to document the difference, but often they are sort of going in the same way. So mood will literally be the patient's own words. Are they sad? Are they happy? Are they angry? Do they feel fine? And if somebody says that they feel fine, what's the fancy word that's used for that? Again, only going through it because it's thrown about a lot, but literally just means that the patient is fine, the patient feels fine. Yeah, euthymia. So you being neutral, thyme being feeling. So the patient is euthymic just means the patient feels fine. What different types of affect are there that you've heard of? Or phrases that are used to, yeah, flattened affect, which is, you know, somebody who's really depressed, for example. It's just, yeah, everything's not going great right now. With the opposite being an expansive affect, like somebody who's manic, who you almost feel the energy coming out off of them. An expansive affect, everything's great. Oh my, you know, have I told you about my business idea? We can become partners in this. How are you feeling today? An incongruous affect, which is just a bit hard to pick up on, which you might get in a patient who's becoming psychotic. So there are lots of different ways to describe it, but generally you've got your normal one, your expansive one, and on the other end, you're sort of flattened or constricted. And incongruous is a bit like, I'm not really getting much from this person. Incongruence itself, meaning is it in line with what the patient reports? Again, if a patient tells you that, you know, again, that they're feeling great, they're really, really, really happy, but their affect seems flattened, that's incongruent. Same thing happens. You have the same thing with delusions. You have mood congruous and incongruent delusions, we'll talk about in a second. Incongruence is worrying. If a patient is incongruent, whether that's between their mood and affect or their mood and their beliefs, so delusions, that's a bit concerning. That's weird, it doesn't happen often, and it means they're a bit higher risk. So that's something to look out for. So P, we move on to perception. What sort of things are we looking for under perception? So not delusions, because delusions aren't a perception. Perfect. Hallucinations come under a perception. Your perception is your ability to detect stimuli. You perceive stimuli. So abnormalities in perception are abnormalities of sensory input. There is a difference between illusions and hallucinations, which Williams mentioned. What's the difference between an illusion and a hallucination? Perfect. Yes, brilliant. So an illusion is a misinterpretation of normal stimulus. There are two things which illusions are quite common in. Substance misuse, so somebody who gets really, really high, for example, and looks at the patterns on the carpet and sees them as spiders, and dementia. So, you know, your elderly person who's got pretty moderate, severe dementia, who sees the coat hanger in the corner of the room as a person. To be fair, that can also happen whilst you're coming in and out of sleep. So not all illusions are abnormal. A hallucination is there is absolutely nothing. There is no sound, but they're hearing something. There is there's sensing a visual stimulus where there is none. So the most common cause of, what's the most common hallucination in substance misuse? So yeah, so visual edges it in terms of substance misuse. Substance misuse is also more likely to get some of the other weirder ones. So substance withdrawal is your most common theme of of tactile hallucinations. So the really horrible ones of feeling things crawling under your skin. That's typical of substance withdrawal. Whereas in primary mental illness, the auditory hallucinations are your most common part. How would you ask somebody if they are hallucinating? How would you word it? Yeah, okay, I quite like that. So have you ever heard or seen things that other people can't seem to? So rather than making it seem like it's necessarily to do with them, just framing it in terms of other people as well. Do you hear things which other people can't hear, see things which other people can't see? If they say yes, I hear things, what do you want to know? If somebody says, yeah, I hear voices, other people can't seem to hear them. There are some quite important things to ask. Perfect. Are the voices inside your head or outside your head? If the voices are inside, if somebody's hearing a voice inside their head, what's that more likely to be? What condition is that actually more common in? So yeah, so internal hallucinations are often referred to as pseudo hallucinations or quasi hallucinations, in that they're not true auditory hallucinations in the nature of something like schizophrenia. Often the person might be hearing their own voice, for example, and it's really common in borderline personality disorder or emotionally unstable personality disorder, as we call it here. And they're called pseudo hallucinations because they're not true hallucinations. It's the person misinterpreting their own inner voice often. Whereas Williams brought up the important point of, do you think it was real? Do you still believe it to be real? This is important because it's assessing sort of their insight, and something that you might notice when people are being treated with antipsychotics is that actually they might still hear voices. It's just now they're able to realize that they're not real. So that's really important. Are the voices inside your head or outside? Like Prakash said, we've talked about inside being not likely to be actual true psychosis. Outside is far, far, far more common. Claudia said, what do they say? Do they talk to you or about you? So what's the most common format of hearing voices in schizophrenia? Perfect, third person commentary. So it's usually two or more voices talking about the person. When does it, what's quite worrying? When do hallucinations become really worrying? What do they start doing that makes you a bit scared in terms of risk? Command, perfect. If people are getting hallucinations which tell them what to do, often they might be things like hurt yourself, hurt other people. That immediately is higher risk. Command hallucinations immediately factor into your risk assessment. So we've talked with perceptions. The main thing with hallucinations is where are they coming from? Outside being more in line with a true psychosis. How many of them are there? Do they talk to you or about you? And what are they actually saying? Are they commanding you? And sometimes a person might not even be talking to you about this, but if you're talking to a person, they keep on turning around, looking over your shoulder, or if they're just talking back to someone who isn't there or laughing, that's a fairly good sign that they are hearing or seeing something that you can't. and that they are hallucinating. So we move on to thought. So moving towards the end now. Thought can be divided into two parts. There is thought content and there is thought form. We'll start with thought content. The way I look at this, because sometimes it can get a bit confusing in terms of the difference, is your thoughts are in this bottle. Your thought content is what is inside the bottle. This bottle has water in it. That is a normal thought, something like, I should probably go get some sleep, or what do I need to get from the shops? If this bottle had blood in it, that is abnormal thought content. That's a delusion. Somebody believing, and it's not the case, that they are being pursued by a malevolent entity or organization. That's what a delusion is. The bottle has blood in it. Thought abnormalities of thought form, which are referred to as thought disorder, that's all thought disorder is. It's a problem with thought form. The thoughts could be normal, it's just they're coming out wrong, is what happens between you opening the bottle and you drinking from it. So between the thought manifesting and you speaking it out loud, anything that goes wrong is thought disorder. And we'll talk a bit about that in a second. In terms of content, these are the things that you actually have to elicit. So thought content is, and perception are the parts which you usually have to ask the person thinks about. So obviously you've got things like investigating thoughts of suicide, and that can go into quite a lot of detail and it's really useful for the risk assessment. Where are they at in terms of that? Are they thinking about it, but they haven't had any ideas about how to do it? Are they really considering it? Have they made a plan? Have they prepared in terms of put a date, a time, gotten the equipment if there's any, settled affairs, writing letters, wills, those, all that's ascending risk in terms of this is low risk, this is probably fine, to this is high risk, we should probably admit this person. Thoughts of hurting other people, and then you've got delusions. Delusions are quite hard to ask about because obviously a person genuinely does believe in them. So the way that I've often seen it asked about, and the way that I ask about it is, do you have any thoughts that other people might think are strange? Remember, the definition is that it's not just has to be a false belief. It's not consistent with the person's social or cultural background, and you can't convince them otherwise. So remember, there are some beliefs that if you're born and brought up over here, you would think, well, that's not true at all. But somebody who was born or brought up somewhere else, that's actually pretty normal for them. So things like demonic possession is something which is accepted in some cultures. And people believing that they're possessed by a demon, you go, well, can I straight up say that you've got a delusion? I mean, I probably think you're psychotic, but I should probably explore this in a bit more detail. Other things like the concept of the evil eye, being cursed, that sort of thing. But the main things are, it's false, it's unshakable, and it's not consistent with them socially, culturally, or religion-wise. You've got this breakdown into primary and secondary delusions. What's the difference with those? Yeah, perfect. So primary delusion comes fully formed out of the blue. Nothing has come before it, whereas the secondary one is, as the name suggests, secondary on another delusion usually. So a primary delusion might be that someone's after me. The secondary delusion will then be something like, my neighbors are trying to poison me, which has come from the first delusion. There are loads and loads of different types of delusions. Your most important ones being your persecuted delusions, which is somebody's after me. Reference. An example of a reference delusion is believing that the news broadcaster on the television is talking about you or to you, and then grandiose, which are the ones which are quite common in mania, which don't necessarily have to be that a person thinks that they are a person of power or historical significance. It could be that they have powers, and you can see why this is quite dangerous. If somebody believes that they are physically invulnerable and runs into traffic, their risk goes up significantly. or somebody believes that they can fly, which also does happen. You've got loads of eponymous ones, which are SBA material mostly, but you can sometimes see them, and they are quite interesting. So going through, what's a Capgras delusion? So not necessarily by robots, Christy, but it's the idea that somebody has, you see your mum and you go, you're not my mum. And you look like my mum, you speak like my mum, but you're not my mum. You've replaced my mum. What have you done with her? So it could be that it's robots who've replaced them. It could be aliens. It could be anything like that. But the important thing is somebody has replaced someone that you know. But then you've got the Fragoli delusion, which is kind of like a bigger version of that. So what's a Fragoli delusion? These two are quite rare. Exactly, yeah. So the Fragoli delusion is the idea that, let's say you've been sacked from your job, and suddenly you start believing that all these different people are actually your boss, who's wearing these different people's face, the barista at Costa, the bus driver. They're all actually your boss, taunting you, keeping an eye on you. He's taken on these people's different faces. Cotard delusions are the ones which are seen in psychotic depression often. So that's delusions of sort of nihilistic delusions. I'm already dead. I'm rotting on the inside. You see them in really severely dressed people. Often the problem with them is they're associated with self-neglect. If somebody thinks they're dead, they're not going to look after themselves. So that can be quite worrying in terms of risk to self. And then Othello delusion. What is it and why is it worrying? Yeah. So Othello delusion is delusional jealousy. It's the belief that your partner is cheating on you, for example. And it's weirdly, from what I've seen, quite a lot of older people happens in. The reason it's worrying is it is associated with homicide. It's got a significant association with the person actually acting through on it and killing their partner, which is why Othello delusion is really worrying. There are a bunch of other types, Declarenbout, which is delusional infatuation, the belief that a celebrity is in love with you. You have to go and meet them. There was a period in time with a psychiatrist reported 3 people simultaneously believed that Brad Pitt was going to marry them. And then you've got your other things, thought insertion, somebody's putting thoughts into my brain, thought removal, somebody's removing stuff from my brain using a chip, thought block, which you might see if a person's talking and suddenly they stop and they go, somebody's taking my thoughts away. Delusional passivity is, again, a more severe one, which is when a person goes, yeah, I can't control, my arms, I'm not moving my arm, somebody else is moving my arm for me. Really quickly, the formal thought disorder. And this is where we talk about the cup or the bottle. And there are loads and loads of different types, some more common than others. So derailment or tangentiality, for example, is when a patient switches very quickly between vaguely related or unrelated topics. Today I went to California, the cat is in the bag. Did you notice that deodorant is flammable? The analogy being, I start drinking from this one, don't even finish it, move on to the next one, don't even finish that. There's a deodorant bottle, I've moved on to that now. Circumstantial speech is different in that they'll move on to other drinks, but they'll come back to the first one. So, in that previous example, let's say you'd asked me about so where did you go a week ago? And I start talking about California. Eventually, after talking about the deodorants being flammable and whatever, I come back to talking about California. Flight of ideas is, again, your self-explanatory one, which is the person is very quickly going through. They're linked, which is what makes it different from derailment and tangentiality. The topics they're talking about do have a link. They're just going through very, very fast. Poverty of speech or alogia is what's seen in severe schizophrenia sometimes, which is they just don't talk. They can't, they're so unwell that they talk either so slowly or they just don't. Perseveration, you know, you ask me, so what's your date of birth? And I go, 8th of May, 1997. And then you go, okay, and where do you live? And I go, 8th of May, 1997. And what do you study anything? 8th of May, 1997. The bottle is long empty and I'm still drinking from it. Echolalia is just repeating what the other person has said. So you say, can I get your name, please? And I go, can I get your name, please? And it goes back and forth. The patient repeats it. So that's literally just drinking what the other person drinks. You've got word salads, which is just random words, no grammatical, syncopal connection, anything. Neologisms, they're just either putting together words which in a way which they're not used for, or making up entirely new words and drinking out of a rubber duck. Clang associations are they're speaking in a way where things rhyme. So the words aren't really linked, but they're doing it because they rhyme. All of these you can pick up by the way the patient speaks. Insight is important. It was mentioned earlier. Insight involves how well does the patient realize what's going on? Is it a person who says, yeah, I know that I need help, to a person who goes, actually, I don't think I need anything, but my family are telling me, so I probably should get checked out, to, no, I'm fine. Why are you holding him here? Let me go. A person who's actively psychotic. The fancy word for lack of insight is anosognosia, just in case anybody wanted to know that. But insight is really important, and it's often the ground for sectioning somebody. If somebody doesn't have any insight into how unwell they are, that's grounds for being sectioned. Finally, cognition, which is same in COOP. Do they know where they are? Do they know what time it is? And do they recognize other people? Grossly, you'd assess that whilst you're talking to them. And if it comes across that they're not cognizant, you might assess it more formally. And this is how you might present it. So Mr. Moose is a 27-year-old male who presented to the emergency department after an intentional overdose. He's well kempt but subdued in behavior and avoids eye contact. His speech was slow, quiet, and normal in tone. He reported feeling utterly depressed and displays a blunted affect. He reported thinking that life wasn't worth living, that he has no purpose in this world, and confirmed present suicidal thoughts and ideation. He denied any abnormal thoughts and perceptions and was not reporting to unseen stimuli. He understands why he's in hospital, although he wants to be let go so he can do it properly this time. He is grossly oriented to time, place, and person. So that might be how you'd summarize a mental state examination, for example, in OSCE. Okay, I think we'll stop here. We'll do risk at the start of the next session, just because it is quite important. So I'll do the start of the next session. If anybody has any questions about this, then drop it in there. Obviously, this will be recorded. I'll put the link to the recording on the Facebook group. I'll put the link to the feedback session on the Facebook group as well. Please put anything in the feedback session that you want to be covered in more detail, perhaps anything that you're not sure of, and I'll make sure to address that. Also, sorry for this overrunning and for the technical difficulties. Do feel free to put less session was too long in the feedback, and I'll endeavor to bring it down. But yeah, I hope that was useful. And if you have any questions, then no worries. No worries. No worries.